So Ed, 15 years ago, you started writing about the chronic care model, which we're all very familiar with now. Where did the ideas come from?
I think initially it came from my clinical practice that it was frustrating that well-intentioned, well-trained physicians couldn't get high levels of disease control among its patients with high blood pressure, diabetes, and other common conditions. Started reading to see why that was. There was an evidence base about how practice could be changed to get better outcomes for patients with these diseases. And I think it was that evidence that we thought needed to be communicated to the practice community in a way that they might find useful.
So talk a little bit more about the role of the patient within the chronic care model.
One of the things that became clear that was wrong was that the patient who is making the decisions about the management of their health and illness 99.9% of the time weren't being considered in the equation. Medical care was doing all of the management and assuming that patients would go home and do exactly what medical care told them to do. And then literature began to suggest that the way we were educating patients wasn't working, that didactically telling them what we thought they needed to know wasn't changing behavior, wasn't improving outcomes, and that what did seem to make a difference was actually collaborating with patients, trying to help them and help us understand their point of view. What was their sense of what the problems were? What was their sense of what the solutions to those problems were? And could we bring that together with what the evidence told us they might need to come up with a plan that they might actually find both consistent with their point of view and their values and worth trying.
So the patient is at the heart of this, but in your latest development of the chronic care model, you have the prepared, proactive team working together to support the patient. Say a bit about who should be in that team.
The only way that all of that evidence-based and other service and meeting the needs of patients can take place is if it's shared. And what we're trying to figure out now is who exactly the provider most cost effectively would share that with, who are effective self-management supporters and counselors. There need to be people on that team who can help patients deal with the coordination issues when they need service outside the practice. There need to be individuals on the team who make sure that patients have their logistical needs met, whether it's transportation or access to appointments, whatever. All of that is what makes for effective primary care. And if the physician has to do it all, obviously it's not going to get done.
So what about patients we talk more and more about these days, patients with multi-morbidity, complex needs? We're not just treating the hypertension or the diabetes, we're treating the person who has several conditions. Is the team model you've described the right one for them?
They're going to need more. They're often going to need help with behavior change. They often need help with just sort of fundamental social needs of transportation, income, housing, and so on. We have to be able to have the capability of changing the configuration of the team depending on the needs of patients, and that obviously is going to require a better connection between primary care practice and and of care, regardless of how complicated the patient is, needs to be someone who, if not a generalist, has generalist perspectives and is willing to take on the comprehensive needs of the patient to assure that those comprehensive needs are met, not necessarily by them, but by coordinating with the variety of services that will meet the needs of that patient, but also has that what the literature calls whole person knowledge. So getting the care plan not only clinically correct, but correct for the age and level of frailty and social and emotional situation is also a challenge.
So when we talk about integration, can I just be clear on this? The benefits really accrue from clinicians working more closely together, from services coming together. It's not about massive organizational change.
No, exactly right. I mean, if it isn't happening at the individual patient level, happening at the agency level is irrelevant.